Hi, my name is Ann Patridge, and I'm a medical oncologist at the Dana-Farber Cancer Institute in Boston. When young women are diagnosed with breast cancer, they not only face the difficulties of a breast cancer diagnosis and treatment, but they often also face the risk of becoming amenorrheic, infertile, and/or prematurely menopausal following treatment. The risk of amenorrhea is related to increasing patient age and treatment received. The more treatment received, particularly with alkylating agents and anthracyclines, as well as the older a woman is, the higher the risk of amenorrhea from treatment and long-term infertility. Tamoxifen, the standard endocrine treatment for young women with endocrine-sensitive breast cancer, is also associated with amenorrhea. However, it does not appear at this time that it causes permanent damage to the ovaries and is more likely to cause temporary amenorrhea, if anything. For some young women, cessation of menses, or infertility and menopause, may be welcome, and it may even improve outcomes for women with hormone receptor positive disease. For many young women, however, the threat of or the experience of infertility after breast cancer may be devastating. And many young women don't welcome menopause, even independent of their desire for a future biologic child. Discussion of this very important survivorship issue should commence early in the treatment decision process, as some women may elect to try to preserve fertility through intervention, and some may even elect to forego some therapy, especially when the risk of the disease is low and the benefits of treatment are modest. It's also important to remember that for a woman who is 38 at the time of diagnosis, the likelihood of immediate menopause due to chemotherapy may be relatively low with standard regimens. However, a woman may be less fertile following chemotherapy even if she continues to menstruate, and she may go through menopause earlier than she otherwise might have. Therefore, especially if a woman is receiving hormonal therapy, often consisting of 5 years of treatment, a woman who's diagnosed with breast cancer, particularly in her 30s, may be at significant risk of infertility in the subsequent years, especially as she heads into her 40s. The options for fertility preservation include cryopreservation of embryos, that is, fertilized eggs, cryopreservation of eggs themselves, or oocytes, or cryopreservation of ovarian tissue. Cryopreservation of embryos is a widely available strategy that is conventional IVF. It's important to know that fertility doctors do this all the time, but they don't like to do it in women who are over age 42 because it is not very successful. And therefore, for our patients who are nearing that age, they need to understand that. Cryopreservation of eggs and ovarian tissue is something that's considered very experimental at this time, and while techniques are improving, relatively few babies have been born to date worldwide using these techniques. All of these techniques have limitations. For cryopreservation of oocytes, or eggs, or embryos, there's the requirement of ovarian stimulation, which may require delays of up to 4 to 6 weeks prior to initiation of breast cancer treatment. Some women may not have this kind of time because they may have higher risk breast cancer, and some women may elect to not undergo stimulation of their ovaries in the setting of concern about micrometastases prior to their breast cancer chemotherapy. In terms of cryopreservation of ovarian tissue, this requires a surgery and removal of a piece of the ovary, which may make a woman slightly less fertile than she otherwise might have been, at least in the short term. Suppression of ovaries using GnRH analogs has been tested widely and is widely available. At the present time, it is not clear that this actually improves fertility rates in women who undergo breast cancer chemotherapy, and thus this should be considered experimental at this time and not something that one should consider a clear fertility preservation modality. Many infertility specialists also are wary of performing in vitro fertilization techniques, including cryopreservation of embryos, after age 42 for women. It's important also to think about, if we preserve fertility, are we comfortable and is it safe for our young breast cancer survivors to get pregnant? Although breast cancer-related outcomes do not appear to be worse in those who have a biologic child after breast cancer, the studies done to date are limited by substantial biases, including something called the healthy mother bias, which basically means that women who go on and become pregnant may have been healthier and have had a better prognosis to begin with from their breast cancer than women who don't go on to become pregnant. And therefore, concerns about subsequent pregnancy remain for some women and their providers. Pregnancy after breast cancer is clearly a very complex and personal decision for a woman who remains at risk for recurrent disease. And it's incumbent on us to help women weigh their personal values, their risk of disease recurrence, their risk of infertility, as well as the treatments needed in order for women to make the best decisions for themselves and allow them to live the best and most full life both through and beyond breast cancer.